I'm Peter Block here in Chicago at the ACC.16 annual meeting, and it is the end of day one. And with me to wrap this up is Kim Eagle. Kim needs no introduction. He's from the University of Michigan, and he and I have been talking about the trials that were in fact presented today. We've come up with two. One is HOPE, the other is the Partner 2A trial. So Kim, I'm going to turn to you for the HOPE trial and ask you to sort of tell folks out there what you think is important about HOPE.
So the HOPE trial is an important study. Nearly 13,000 patients from around the world were randomized to two different strategies. One of them is Crestor or placebo. Another is a combination antihypertensive drug, candesartan and hydrochlorothiazide at low doses. It was a 2x2 design. Patients had several risk factors for the most part, but they did not have established coronary heart disease. The trial that looked just at Crestor, 10 milligrams a day versus placebo, was favorable. It showed a significant reduction in risk out at about 4 or 5 years, from around 5% to 3.5% of primary endpoints. And as you might expect, that was a similar risk reduction in the combined trial where rosuvastatin was there. What was interesting, Peter, in the just blood pressure lowering arm, where the blood pressure was dropped by about 6 points from the combination pill, there was not a significant benefit in reducing risk except if the blood pressure was elevated, which I guess is no surprise.
Yeah, well, the elevation, Kim, was greater than 140, or close to 143.5, so give it 145 just for the sake of argument. And I'm not surprised at that, but I'm sort of surprised, aren't you, that there wasn't a little bit of a signal coming out of the lower blood pressure?
Well, after SPRINT, which was released in the fall, we thought that maybe substantially lower is better. Certainly this part of the HOPE trial does not support that notion. But again, these were not patients who were primarily being treated for hypertension. They had risk factors. Some of them did have mild hypertension, but not severe hypertension.
Yeah, let me just say a word about my thoughts about the cholesterol business, because LDL did come down significantly.
LDL dropped about 35 points.
Yeah, HDL didn't change very much. But the interesting thing was that the outcomes really were significantly changed. So the question is it really worthwhile? How much risk do you have to have in order to treat a patient? And I think the answer is, from this trial, you didn't need a lot of risk.
So if you look at the current guidelines that recommend preventive therapy, if your risk over the next 10 years is 7.5%, these were much higher risk than that. These people had about a 5% risk over a period of 5 years. So lowering that with Crestor was highly beneficial.
Okay, let's move on. Partner 2. It gets to be my turn.
Okay. It's Peter's turn.
Thanks. So TAVR 2. TAVR 2, of course, TAVR 2, it isn't TAVR 2, it's Partner 2, but essentially it's TAVR 2A. So transcatheter aortic valve replacement in intermediate risk patients. An interesting study. It was a study using the XT valve, the Edwards XT valve, and interestingly, it showed a lot of things that we anticipated. Some of the things we didn't anticipate. One of the things it did show, if you look carefully, is that if you only looked at a certain subgroup of patients, these patients, in fact, did have better outcomes than the surgical patients. Wow. And that's an interesting point because, as you remember, the Medtronic valve, core valve, also has shown that in its early trials. So I think this sort of supports each other. It doesn't make any difference to me what valve you basically are using or should use, but these essentially give TAVR a better name because we're supporting data on both sides.
Now, is this a higher profile valve?
This a little bit, but the best valve, in fact, is the valve that's coming out now, the SAPIEN 3, and that's a valve that is just now being evaluated in the subgroup analysis. Those are the patients that seem to do the best. Okay. And in fact, they have far less paravalvular leak, et cetera. Going forward, those are the valves we're going to be using. The second generation valves will also show much less paravalvular leak. Short version about Partner 2 is promising results, very important results in going lower on the scale of risk for these patients with aortic stenosis. And I guess the question then comes to be, what about the patient that really has very low risk? There's a trial underway in Europe. People are doing some registries with this. We don't have a big trial in Europe yet, but hopefully we will see some more data coming out for very low risk patients. And I think it's going to be a judgment call as to when you stop using TAVR. It seems to be pretty good therapy.
It does. The questions of valve regurgitation, need for a pacemaker, stroke, it seems like we're getting ahead of all of
Well, stroke is now down to 1% and pacemakers are down to less than 10%. I think we're good and good as these new valves get to be better and better in their design. And it's amazing how much design improvement there's been. So there you have it. That's a quick wrap up for 2 major trials today. We think they're going to be important trials going forward. Certainly hope will be. And TAVR is just going on to be a good way to take care of patients with aortic stenosis.